high-grade bursal size rotator cuff tear, takedown were presented by Dr. Bancha Chernchujit from Thailand.
Good morning. I'm Dr. Bancha Chernchujit from Thammasat University, Bangkok, Thailand. So my talk is about the high-grade bursal side tear, takedown or not. Thank you, Sugaya, for this kind invitation. It's my great honor to be here. Danny, the previous speaker, is my good friend also, but I didn't agree with him. For the bursal side tear, you take down, okay? But I think there are two options for you: inside to repair or take down and repair. Okay, I prefer to do inside to repair. Why? So inside to repair, you have less invasive, and also you re-establish the native footprint because the articular side is still there. You don't have to take down and minimize any length tension mismatch, less risk of constraining. The drawback is you may jeopardize the viability of the remaining cuff tissue and disrupt the healing potential. For the takedown and repair, it's simple because easy. You take down and you use a crocodile to grasp it. But actually that you already cut the articular side, the capsule, and also tear debridement and removal of the tissue. The drawback is you excise the remain good tissue, taking down the intact capsule and also the length tension mismatch and more constraining. Very few literatures compare the results of these two techniques in bursal side tear alone. Most of them is not exclude the articular side, and they found that there's no difference. Wolf in 2006, he mentioned that he preferred to not to take down, fix it, and the advantage is that intact articular fiber is act like internal spring, while an anatomic footprint is recreated and minimize length tension mismatch. So this is the good paper from my friend Yang Soo Kim. He compared the bursal side tear, articular side tear, comparing the in situ repair and the takedown. They found that if the bursal side tear re-tear rate was higher in takedown, in tear completion group, but the articular side tear, there's no difference in situ repair or you do the takedown. So that's prefer to do in situ repair for the bursal side. So I published in arthroscopy technique about the knotless suture bridge, anchorless of the middle row. So my prefer is you can get a wide anatomic footprint, minimize leg tension mismatch, and also improve the healing potential at the articular side. First patient, 40 years old male, has right shoulder pain, and also he has a X-ray. There's a articular big also fight. This is a bursal side tear, intact articular side. So articular side looks so nice like that. Why you need to cut it? This is a big spur, and you look at the bursal side, there is a acromion. We found that most of the cases they always have the acromion at least. Sometimes they have irregular spur or healed or Q spur. So most of the time in the bursal side we need to do acromioplasty. It's totally different from the articular side tear. And this is the intraoperative pictures. We found that the patient had high-grade articular side bursal side tear. So we made a big bite through the remaining rotator cuff, but preserving the articular side. Very important, you need to check in the joint that your suture is not include the biceps. And then we make a suture bridge. I prefer to use a 6 suture, 6 and 6 is 12. We call dozen suture bridge. So the good thing is this technique you can separate the pressure distribution nicely on the footprint. And this is a post-operative MRI. The bursal side is healed nicely, and the patient has very good results. And this type of patient will recover very fast because you preserving the articular side. This is a 43 years old patient who has a chronic shoulder pain for 3 years. But his X-ray look always have the large acromion spur like this, and also downsloping. So this is quite a little bit strange because this patient have very thin attachment. You see, at the footprint there's no rotator cuff, but the cuff look nicely. It's like a very good remodeling of the bursal side. Okay. So we look at the arthroscopic image. We found that the cuff is attached at the medial side. So first I do the raw surface on the footprint, make a microfracture, and try to catch the rest of the cuff, okay, to cover the footprint without taking down the articular side. Make a big bite. So this scenario is not so common. Most of the time we feel like patient has like a flap, but this is like very nicely modeling. So after the repair, we can reduce the cuff back to the footprint. And this is the MRI after the study. So we got the case series. We got the 27 shoulders, and 14 we put the anchor on the medial row, and another 12 we did not put the anchor on the medial row. We calculate the critical shoulder angle and also the acromion index. And most of our patients have the spur at least. They have Q spur or irregular spur. The results, we found that the patient had a very good result: shoulder score, ACS score, VS score after the repair, and also most of them have a high critical shoulder angle than acromion index. And articular side preservation act like a sprint, okay, to repress the medial row anchor. We found that the shoulder score, and also we do MRI using Sugaya MRI post-op evaluation. 44% they have a grade 1, 40% had grade 2, 11% had grade 3, but this patient always have an old age patient. Only one patient had a partial disruption. So totally is about 97% that have a good healing using this technique. So in conclusion, high-grade bursal side tear, take down or not, please do not take down. Articular side preservation act like internal spring. Repress the medial row anchor. No need for the medial anchor. You save money also. Okay, you put only 2 anchors and re-establish normal footprint. Minimize length tension risk mismatch. Lower retaliate. Only 3.7%, and almost always you need to do acromioplasty. Thank you.
Thank you.